Welcome to virtual APSA 2021, Pediatric General and Thoracic Surgery session. I am one of your moderators, Dr. Bethany Slater from the University of Chicago.
And I'm Sohail Shah from Texas Children's Hospital in Houston.
And I am David Lazar from the University of California, San Diego and Rady Children's Hospital.
We are all members of your 2021 APSA Program Committee. We are delighted to present the following posters and oral presentations. We have 7 posters that will run in succession without any video discussion, but you are welcome to ask questions in the chat function of the authors who are present today. After the posters have all run, we will present a short recap of some of the posters that we felt were highlights. Thereafter, we will take on 8 of the abstracts in your session 4, dedicated to general pediatric and thoracic surgery. So without further delay, here are the 2-minute poster presentations of our session. Our first poster session will be presented by Dr. Elizabeth Su from Northwestern University, entitled Opportunities for Improvement in Pediatric Ovarian Tissue Cryopreservation, Evaluation of Tissue Fragments and Routine Punch Biopsies.
Ovarian tissue cryopreservation, or OTC, is the only fertility preservation option available for prepubertal female patients, but this procedure is optimized for adult ovaries. We hypothesize that prepubertal patients are more likely to lose primordial follicles due to the lack of a defined corticomedullary junction. Prepubertal FCFs displayed an average total follicle density of 6 versus 0.2 follicles per millimeter squared in postpubertal FCFs. Average primordial follicle density was 4.3 in prepubertal FCFs versus 0.1 follicles per millimeter squared in postpubertal FCFs. 45.5% of FCFs from prepubertal patients contained primordial follicles versus 10.7% of postpubertal FCFs. 35% of prepubertal and 67% of postpubertal punch biopsies displayed a defined corticomedullary junction. In samples that displayed a junction, no difference was detected in cortical thickness. Primordial follicle density was 57.8 in prepubertal samples versus 1.7 follicles per millimeter squared in postpubertal samples. Average depth of deepest primordial follicle from ovarian surface epithelium was 1.96 in prepubertal patients and 0.54 millimeters in postpubertal patients. In conclusion, FCS from prepubertal patients were more likely to contain primordial follicles and demonstrated increased total and primordial follicle density than FCFs from postpubertal patients. Ovarian structure differs between pre- and postpubertal ovaries. Prepubertal ovaries are less likely to display a defined corticomedullary junction and primordial follicles at deeper depths within the ovary when compared to postpubertal ovaries. These preliminary results demonstrate the need for additional investigations into the unique structure of the pediatric ovary over the pubertal transition to inform new OTC standards that maximize the fertility potential of tissue saved for prepubertal patients.
Our next poster in this session will be presented by Hira Ahmad from Nationwide Children's Hospital. Her poster is entitled, Does Routine Botulinum Toxin Given After a Primary Pull-Through Decrease the Incidence of Hershbergs-Associated Enterocolitis?
Hershberg disease is a developmental disorder of the enteric nervous system, which is characterized by the absence of ganglion cells in the myenteric and submucosal plexus of the intestine. Hershberg-associated enterocolitis is a condition of unknown etiology, which is seen in a subset of children post-pull-through. We hypothesize that post-op injection of botulinum toxin, or BT injection, in the internal anal sphincter will reduce the incidence of post-op enterocolitis. To test our hypothesis, we performed a retrospective review of all patients who underwent primary Swenson pull-through for Hershberg disease between April 2014 and December 2019. We also determined which patients had routine post-op BT injections. We define enterocolitis episode as initiating treatment for obstructive symptoms in the inpatient or outpatient setting with antibiotics and irrigations. This study was approved by the IRB. We had a total of 70 patients. 27 patients were female and the median age was 6 months at the time of the pull-through. 56% of the patients had Hershberg disease limited to the sigmoid colon, and the rest of the patients had transition zones proximal to the sigmoid colon. This included patients with total colonic Hershberg. We had 2 groups. Group A received routine post-pull-through BT injection at 1 month, and Group B did not. We found that routine post-pull-through BT did not significantly change the incidence of enterocolitis. The patients in the BT group developed enterocolitis significantly sooner than the patients in the non-BT group. More patients in the BT group required subsequent BT injections compared to the patients in the non-BT group. We thus concluded that routine post-op botulinum toxin injection did not reduce the incidence of enterocolitis. A prospective study is necessary to confirm these findings. Thank you.
Our next poster in this session will be presented by Nikki Check, who is a physician's assistant at Boston Children's Hospital. Her poster is entitled Sinusectomy, an effective in-office treatment for pilonidal disease in adolescents.
Pilonidal disease is a common acquired adolescent condition. Hair follicles in the gluteal crease become inflamed, which lead to the formation of holes in the skin, pilonidal pits. Pits allow hair and other foreign material to travel through the skin, leading to subcutaneous sinus tracts and inflammatory pockets, misnamed cysts. The traditional surgical treatment, resection of involved tissue, is morbid, expensive, and requires a prolonged period of activity restrictions. We report a large series of adolescents who underwent a sinusectomy, a minimally invasive procedure that can be performed in a clinic. It requires local anesthesia, a 2 or 3 millimeter skin biopsy punch to excise the pits, which are then closed with a stitch and possibly opening the pocket. Patients were seen in our pilonidal care clinic from December 2015 to February 2020. Most sinusectomies were performed with local anesthesia. Patients were advised to take ibuprofen or acetaminophen as needed and had no activity restrictions. They were followed until demonstration of wound healing and resolution of cleft hirsutism. We performed 301 sinusectomies in 205 patients. Patients averaged 17 years of age with a BMI of 26.7. 59% were male. 94% of procedures were done with local anesthesia in the clinic, while 6% required general anesthesia secondary to behavioral disorders. 31% of patients had mild disease, 50% moderate, and 18% severe. 66% of patients underwent one sinusectomy, 24% underwent 2, and 10% underwent 3 or more. Of the 69 who underwent a repeat sinusectomy, 80% were for disease recurrence and 20% were part of a staged multi-visit approach. 77% underwent concurrent laser epilation. At an average follow-up of 11.8 months, 71% experienced complete resolution of disease, 9% continued to receive care, and 20% were loss of follow-up. Sinusectomy is an effective and well-tolerated minimally invasive procedure for pilonidal disease that can be safely performed in a clinic setting and repeated as needed, avoiding a major disruption in an adolescent's life.
Our next poster in this session will be presented by Dr. Nicholas Skretish from Rush University Medical Center, entitled The Effect of Standardized Discharge Instructions After Gastrostomy Tube Placement on Postoperative Hospital Utilization.
Gastrostomy tube placement is the third most common non-cardiac pediatric surgical procedure performed, and post-placement hospital utilization is high, with rates of 30-day readmission and ED visits as high as 4% and 20% respectively. Our goal was to determine if post-operative standardized discharge instructions reduce the rate of hospital utilization. This was a retrospective single-institution study from 2014 to 2019 in which we evaluated hospital utilization rates pre- and post-implementation of standardized discharge instructions. These instructions consisted of a 30-minute session by a trained nurse practitioner in which they taught patients and caregivers, when appropriate, how to use the G-tube, how to manage typical problems, as well as how to vent and replace it. They also had caregivers practice on a model doll and provided written instructions with details of what was discussed, as well as the surgery performed, by whom, with contact details of our clinic. We then assessed 30-day and 1-year hospital utilization, including ED visits, unplanned office visits, readmissions, or phone calls. Although there was not a significant increase in odds of any event within 30 days, there was an increase in odds of having an office visit at 30 days or any event, ED visit, office visit, or phone call within 1 year for patients not receiving standardized discharge instructions. The 30-day and 1-year incident rate of any event, phone call, or office visit was also significantly higher for those not receiving standardized discharge instructions. Finally, on adjusted time to event analysis, the hazard ratio is significantly higher in that group too. In conclusion, our standardized discharge instruction protocol reduced hospital utilization across various domains. The prolonged effect of a single in-depth teaching session is particularly important in rural or international locations without immediate access to care, as it empowers patients and caregivers to manage their gastrostomy tubes without need for hospital utilization.
Our next poster in this session will be presented by Luis Ruffolo from University of Rochester Medical Center, entitled Postgastrostomy Complications and Emergency Department Utilization are Tied to Community-Level Social Determinants of Health.
Good afternoon, and thank you for the opportunity to present our work from the University of Rochester. Pediatric gastrostomy tubes have been shown to be associated with high healthcare utilization after discharge, which frequently manifests as emergency department visits related to G-tube dislodgement. Our previous work, investigating the drivers for emergency department utilization, found a strong correlation between non-Caucasian race and high emergency department utilization. We hypothesized that community-level social deprivation indices, which codified social drivers of health, can help stratify children with an increased risk of complications after G-tube placement. Formed a retrospective review of all pediatric G-tubes placed between 2011 and 2018. Area deprivation indices and social deprivation indices were calculated utilizing the patient's home address at the time of surgery. Logistic regression between indices and high ED utilization was performed along with univariate analysis of indices and outcomes after G-tube placement. Shown is a map of the Greater Rochester area with census blocks color-coded by area deprivation index. Overlaid in dots are every child analyzed within the study stratified by high or low ED utilization. A strong correlation was discovered between a child's area deprivation index and whether that child presented to the emergency department 2 or more times. Beyond the association with increased G-tube ED visits, we also found an association between higher area deprivation index and more frequent early G-tube dislodgements. Next, we performed a subgroup analysis within the African American and Caucasian population. We found that both indices continue to stratify higher at-risk children with the need for more ED visits, early G-tube dislodgements, or the need for procedures related to G-tube dysfunction. We found area and social deprivation indices predict poor outcomes after G-tube placement. Going forward, we would like to use these indices to identify children that may benefit from telemedicine and home nursing interventions. Thank you for your time.
Our next poster in this session will be presented by Denise Klinkner from the Mayo Clinic. Her presentation is entitled Minimally Invasive Sutured Open Reduction Internal Fixation of the Slipped Rib, a novel method of alleviating intercostal neuralgia from slipped rib syndrome in pediatric patients.
Slipped rib syndrome affects 1 or more of the 8th to the 10th false ribs, triggering pain. In the pediatric population, SRS has been managed with analgesia, intercostal nerve blocks, and costal cartilage excision with mixed results. A novel technique of minimally invasive sutured open reduction and internal fixation of the slipped rib without costal cartilage excision has alleviated intercostal neuralgia in adult patients. Here we report the first series of this procedure in pediatric SRS patients, hypothesizing improved pain and quality of life scores using validated standardized outcome measures. After IRB approval, we performed a retrospective review of pediatric cases of SRS treated at 2 institutions since 2020. Clinical details, including workup, medication needs, and results of the short form cerebromusculoskeletal pain screening questionnaire, were collected pre- and postoperatively. Questionnaire outcomes were compared using the Wilcoxon Sign Rank Sum test. SRS was diagnosed clinically, and 17 patients ages 12 to 21, mean of 17, underwent suture fixation by 2 surgeons. 14 were female and 3 were male. 5 were hypermobile and 4 were trauma-related. Suicidal ideation was present in 3. Symptoms had been present for a mean of 19 months and range of 1 to 48. 1 had right-sided repair, 7 left, and 9 had bilateral repair, 4 of which were in a staged fashion. At 1-month follow-up, there were no surgical complications, and narcotic medications used postoperatively were discontinued. There have been no reoperations. 1 patient was diagnosed with functional disorder postoperatively. Overall, patients reported significantly less pain, and at 6-month follow-up had no pain and no medication needs. Pediatric patients with slipped rib syndrome demonstrated an excellent response to suture fixation without costal cartilage excision in this pilot. Long-term data are needed to ensure longevity of response and durability of repair. Thank you to my co-authors for assistance with this project. Please contact me with any questions or comments.
Our last poster in this session will be presented by Dr. Sam Linton from Lurie Children's Hospital, entitled Hospital Volume Outcome Relationship for Pectus Excavatum Repair.
We performed a retrospective cohort study of over 7,000 patients ages 10 to 21 who underwent elective pectus excavatum repair by one of 408 surgeons at any of the 47 hospitals in the FIS database in order to determine the relationship between provider volume and odds of a surgical complication. Hospitals and surgeons were each aggregated into quartiles based on average annual volume, comparing unadjusted average complication rates between quartiles. Hierarchical logistic regression was then used to determine a patient's odds ratio of surgical complication based on their provider's volume quartile. Hospital and surgeon volume were examined separately, controlling for 7 covariates and additionally controlling for hospital effects in the surgeon model. Hospital volume quartiles 2, 3, and 4 had unadjusted complication rates below the overall average and about half the rate of the hospitals in the lowest volume quartile. Our hospital regression model showed that compared to quartile 1, patients using hospitals in the 2nd, 3rd, and 4th quartile had a 65%, 59%, and 67% reduction in odds of a surgical complication, respectively. Surgeon-level analysis showed that both the 1st and 3rd volume quartiles had unadjusted complication rates above the overall average rate. Only patients going to surgeons in the 2nd volume quartile had significantly reduced odds of a complication compared to the lowest volume quartile. We found that undergoing pectus repair at a hospital performing more than 10 cases a year is associated with an over 50% decrease in a patient's odds of complication compared to patients undergoing surgery at hospitals not meeting this volume threshold. There was not a progressive benefit to increasing volume between subsequent quartiles. This significant reduction in the odds of complication for patients going to hospitals performing more than 10 cases a year supports further investigation into procedure-specific case volume minimums as a hospital quality metric.
Thank you to all the authors for these enlightening posters. The three of us would like to provide a brief synopsis of what we felt were the learning points we took away from some of these posters. I was particularly interested in hearing about the Botox after pull-throughs for Hershbergs disease. I thought it would be really great if there could be a method to decrease enterocolitis after a pull-through. And this study, they injected Botox about a month after the operation to see if it would decrease the rate of enterocolitis after the pull-through. In fact, they found that it did not decrease the incidence of enterocolitis after a pull-through for Hershbergs, and in fact found that the enterocolitis episodes happened faster than in the group that did not have Botox injections.
Hey, Bethany, I thought another interesting presentation was by Nikki Check, a physician assistant at Boston Children's. She did a very nice job summarizing their experience with utilizing sinusectomy for the treatment of pilonidal disease in adolescents. They demonstrated the feasibility of performing the procedure in the clinic under local anesthesia and the overall good outcomes associated with this less invasive procedure. I found it particularly interesting because although a lot of us have adopted this at our institution, we still continue to do this in the operating room, and the opportunity to do this in the clinic is an interesting finding.
And one other poster I found interesting was the one done by Dr. Sam Linton and the group from Lurie Children's Hospital. They had examined the relationship between hospital volume and outcome in children undergoing pectus repair. And they utilized the FIS database and examined the outcomes of children undergoing pectus repair over a recent 7-year period. Using logistic regression modeling that controlled for clustering and several covariates, they demonstrated a lower odds of complication at the high volume centers, which were quartile 2 through 4, as compared to the low volume centers in quartile 1. Interestingly, this relationship did not necessarily exist between the high and low volume surgeons. And as a result, these authors concluded that undergoing pectus repair at a hospital performing more than 10 procedures per year was associated with a greater than 50% reduction in the odds of a complication.
Thank you again to all the presenters. We now want to switch gears and hear from our scientific session presenters and their respective invited discussants. Each 4-minute presentation will be followed by a 4-minute interactive discussion between the author and a selected discussant. You are also encouraged to chime in with questions in the chat box that will be addressed by our presenting authors. There are 8 abstracts in the session dedicated to general pediatric and thoracic surgery. Our first abstract in the session will be presented by Dr. Rebecca Saberi from University of Miami, entitled Ovarian Preservation and Recurrent Torsion, both less common than we thought.
Hello, my name is Rebecca Saberi, and I'm going to be discussing ovarian preservation and recurrent torsion, which are both less common than we thought. I have no disclosures. So a little background information. Historically, Total oophorectomy was the standard of care for managing ovarian torsion. However, current guidelines support detorsion as the preferred method of management. Nevertheless, ovarian preservation surgery continues to be underutilized, and long-term readmission outcomes are largely unknown. So the objective of our study was to compare nationwide readmission outcomes of total oophorectomy, TO, versus ovarian preservation surgery, OPS, for the treatment of pediatric ovarian torsion. We used the nationwide readmission database from 2010 to 2014 to look at patients who were less than 18 years old with a diagnosis of ovarian torsion who underwent surgical intervention with either TO or OPS. Patients were excluded if they were missing procedure details for index hospitalization. Our primary outcomes included readmission within the year and retorsion rate. Overall, we had 6,028 patients included in our study, with an average age of 13 years. 54% came from low-income households. 68% of operations occurred at large hospitals and 74% at teaching hospitals. The most common comorbidities were obesity and chronic pulmonary disease. During index hospitalization, we had a 50-50 split for the management of ovarian torsion, with 50% undergoing TO and 50% undergoing OPS. The majority of patients underwent an open approach, with only 47% receiving a laparoscopic approach. There was also an 11% rate of incidental appendectomy performed. The most common secondary ovarian pathology included cyst and benign mass. And it's important to note here that the presence of a secondary mass did not necessarily predispose patients to undergoing TO, as 57% of patients who underwent OPS also had a secondary mass. Overall, there was 265 patients readmitted, 2% within 30 days and 4% within the year of index hospitalization. Our overall recurrent torsion rate was 0.2%. The most common secondary ovarian pathology on readmission was cyst, malignant mass, and benign mass, which is consistent with current guidelines that suggest a 3-month follow-up after OPS in the presence of a mass in order to rule out malignancy. So to compare outcomes, ovarian preservation had shorter hospital length of stay, was less costly for hospitals, had the same readmission rate as TO, did not result in missed malignancies, and had the same risk of retorsion. And it's important to note here that the risk of retorsion in the TO group was in the contralateral ovary, which may suggest that there are pathophysiologic factors at play that predispose this group to torsion. So to conclude, OPS is equivalent to TO in terms of readmission rates, missed malignancy, and recurrent torsion. However, half of patients with ovarian torsion are still undergoing TO, which may suggest that we have room for improvement in our management of ovarian torsion by increasing the utilization of OPS. I would like to acknowledge the co-residents and faculty members who contributed to this study. These are our references. And this is my contact information. I'd be happy to answer any questions that you may have. Thank you so much for listening.
Thank you, Dr. Saberi. The invited discussant for this paper is Dr. Erin Rowell from Lurie Children's.
Thanks, Rebecca, for your presentation. You deliver this in such a clear, articulate way, and you have a very large number of patients from the database that you used. This topic of ovarian preservation is so important, and your presentation brings up some interesting questions for me. First, the fact that 53% of the cases were open suggested to me that the surgeons in those cases might have suspected a malignancy and wished to avoid intra-abdominal spill. Can you comment on that?
Yes, so that's definitely a possibility. However, due to the granularity of data that's provided by the NRD database, unfortunately, we're not able to determine the rationale for the open versus laparoscopic approach. With that said, though, our data does correlate with the literature, which indicates that only 1% to 2% of all torsion cases are a result of a malignancy, and 53% of the procedures that were performed in our study were done open. Of those, only 14% were conversions from lap to open, meaning that the majority of surgeons did still go straight to an open approach.
Okay. Also, can you tell me a little bit more about the readmission data? Were the readmissions that you noted in the 2% of patients that were readmitted within 30 days, due to the presence of a mass, or do you know that? And why were they readmitted? And could that possibly be because there was an attempt to spare the ovary and then there was a need to do like a completion oophorectomy afterwards?
So that's an excellent question, and actually one of the reasons we initially wanted to investigate this topic. However, once again, unfortunately, the NRD doesn't allow us to determine if the readmission was planned or emergent. But what we do know is that of those who were readmitted within 30 days, 18% underwent an operation on their ovary. And of those that were reoperated on, 87% had a mass, the majority of which were benign. So we can't really decide what the reasons were because that's not given to us in the database, but those are the numbers that we have.
Okay. And as a third question, maybe this is just more speculative and kind of related to the answer you just gave. Do you think that we as pediatric surgeons should be willing to accept the need for a potential reoperation for malignancy following an ovarian sparing detorsion and potential mass excision?
So based on our findings of less than 1% of all index torsion operations having a malignancy, our answer is yes. We shouldn't be afraid to perform an initial ovary sparing detorsion, followed by, allowing the inflammation to decrease, and then if necessary, potentially following up to perform a better excision electively. That is, of course, assuming that the patient will have appropriate means to follow up.
Great. Thanks so much. Those are all my questions. Dr. Perez, did you have anything you'd like to add?
No, I think I agree with all your questions. I think that was part of the reason we did the study. One was to figure out what was the true rate of retorsion, but also what's going on with those patients that go home and, if they follow up, we shouldn't be afraid. And that's why I love that third question. We shouldn't be afraid of, detours. If you don't see them as well, just detours, wait for the information and just do a better operation down the road instead of just trying to, excise it and get into a tumor or whichever the problem is.
Okay, great. Thanks so much to both of you.
Thank you so much.
Thank you, Dr. Saberi and Rowell.
Our next abstract in this session will be presented by Yuri Kozlov from Pediatric Hospital in Irkutsk. His presentation is entitled Phelps, Pediatric Hernia Extraperitoneal Ligation and Percutaneous Suturing, Comparative Results of Using of a New Method of Laparoscopic Treatment of Inguinal Hernia in Children.
Phelps, Pediatric Hernia Extraperitoneal Ligation and Percutaneous Suturing, Results of Using of New Method of Laparoscopic Treatment of Inguinal Hernias at Children. The basic principle of correction of inguinal hernia in children is the high extraperitoneal ligation of the processus vaginalis. This maneuver is currently implemented primarily for laparoscopy. Despite the effectiveness, laparoscopic methods of treatment of inguinal hernia are still accompanied by the development of hydrocele and recurrency, comparable or worse than after open treatment. The cause of this complication after the use of extraperitoneal methods is the result of eruption of abdominal wall tissue by hernial ligation. The special constructor Toxin needle is used. The lumen of the needle contains two ligatures of different colors. One, violet, of which is an endless loop. The other, green, is a hernial ligature located in the lumen of the needle. This device is inserted percutaneously into the projection of the outer rim of the internal inguinal ring until it appears in the peritoneal space. Then the end of the needle moves medially towards the lower semicircle of neck of hernial sac, under the peritoneum, over the elements of spermatic cord, and push it into the free abdominal cavity. The hernial ligature is pulled out from the lumen of the needle. The needle is then removed, although that its end is in the preperitoneal space at the site of the initial puncture. Repeated needle movement in the medial direction is performed extraperitoneal bypass of the upper semicircle of the hernial sac. After this, in the violet loop, the end of the green ligature is placed and extracted to the outside. The ends of the hernial ligature is extracted to the outside so that Through one puncture hole, two ends of the hernial ligature come out on the skin. The knot of hernial ligature is tied, while the hernial knot is located peritoneally. The same principle is used in girls. We demonstrate the results of laparoscopic treatment of 705 patients with inguinal hernias. Of these, 260 patients were operated using the new Phelps technique. The remaining 445 children received the cell technique. Both groups of patients were comparable in terms of demographic parameters. The study demonstrates the equally enhanced recovery of patients after using both methods of laparoscopic treatment of inguinal hernias. We found a statistically proven difference in the incidence of recurrence of this disease as a result of the application of the innovative Phelps technique. Phelps is the new original technique of laparoscopic herniorrhaphy, which allows performing ideal placement of a knot of hernial ligature at the level of the peritoneum, similar to open technique. Placement of a knot at the level of the neck of the hernial sac at net over the upper neurosystem muscles is expected to lead to reduction of postoperative hydrocele and recurrence. Phelps is easier, faster, and safer laparoscopic technique for treatment of pediatric inguinal hernia. Thanks for your attention.
Thank you, Dr. Kozlov. The advisor discussant for this paper is Dr. Matthias Bruzzoni from Stanford University.
Well, hi, Dr. Kozlov. I really enjoyed watching your presentation and technique. So thanks so much for showing that. I think it's super creative, and I think it does follow many of the principles we follow to repair these hernias laparoscopically. You know, we used to use the seal technique all the time in our institution, and we don't think necessarily the knots spitting out are the problem. In fact, we saw maybe 2 or 3 over the past 10 years after doing many hundreds of these. And to us, the key is to make a good subcutaneous pocket to bury that knot. But that being said, I studied the seal technique, and we saw a pretty high recurrence rate in our institution, about 4%, and that worried us a lot. One of our partners, former partners, Sanj Datta, suggested that we do a double pass instead of a single pass. So we modified the seal technique, and we started doing double passes, and our recurrence rate dropped to 1%. So I just want to get your thoughts on that. You know, how much are you focusing on the knot spitting out versus on sort of the single pass or the double pass, which we feel is a more sort of long-lasting repair? Do you think this is something you could do with your technique to modify it? I guess you have very good results already, but that's sort of one of the thoughts I had, that sometimes, yes, if the knot doesn't get buried well in the subcutaneous tissue and eventually it spits out, you could get an early recurrence. But the ones I've seen are more 6 to 12 months after the repair. So even if you have to remove the suture, the repair is still intact because everything is healed. So thank you so much for the technique, and looking forward to seeing more of your work out there.
Yes, okay. Thanks, Matthias, for questions. And despite the effectiveness, laparoscopic methods of treatment of inguinal hernia are still accompanied by development of hydrocele and recurrence comparable or worse than after open treatment. Incidence of recurrent hernia when using laparoscopic method of treatment of inguinal hernia from 1% to 5%. In my series, it is 2%, and your series 4%. This naturally required a revision of standard laparoscopic techniques and led to the development of new techniques. This gave results. You cut the frequency down to 1%, and me down to 0%. The main reason for failure is after the use of extra peritoneal laparoscopic techniques is so-called sudden light effect, where the suture cuts through abdominal wall tissue and increased tension and distributed across hernial ligature. To overcome this drawback, we presented original technique of laparoscopic extra peritoneal ligation of the hernial sac, which allows performing a complete extraperitoneal bypass of hernial neck with tying and placement of hernial ligation knot at the peritoneal level in the manner of open surgery, which eliminates the risk factor of recurrence. The method of laparoscopic transcutaneous inguinal herniorrhaphy with high transfixation suture ligature of the hernia sac proposed by you is quite interesting, and it is reveals that the use of double ligation can reduce the risk of eruption of the abdominal wall tissues, which will naturally reduce the risk of recurrence. The advantage of my FELS method is based on the fact that using this for the treatment of inguinal hernia in children, it is possible to place hernia ligation around the neck of the hernial sac ideally, as is done in case of open surgery, without grabbing and depositing in the node of abdominal wall tissues, which potentially contribute to recurrence in disease as a result of eruption of aponeurosis and muscles of the abdominal wall. I hope that both methods are intended to reduce the tension of hernial ligature on the tissues of abdominal wall to prevent the septum-like effect. It is possible that for large inguinal hernias in children where strengthening of aponeurosis is necessary, I will use your technique.
Great, thank you very much.
Thanks.
Thank you, Drs. Kozlov and Brazzoni, for that excellent presentation and discussion.
Our next abstract in this session will be presented by future Dr. Parisa Oviedo from Rady Children's Hospital in San Diego. Her presentation is entitled The Impact of Routine PACU Extubation for Pediatric Surgical Patients on Safety and Operating Room Efficiency.
Hi, I'm Parisa. I'll be talking to you about the impact of routine PACU extubation for pediatric surgical patients on safety and OR efficiency. Maximizing OR efficiency is essential for hospital cost containment and effective patient throughput. ORs generate 2/3 of hospital revenue and account for 1/3 of hospital expenses. Therefore, every minute saved in the OR has a substantial impact on hospital finances. And though difficult to quantify, a recent study of California hospitals found that 1 minute of OR time costs $37. Most pediatric anesthesiologists typically extubate patients in the OR. In contrast, we have a longstanding protocol of PACU extubation that is done by nurses with an anesthesiologist immediately available. Children are extubated in the PACU after typical extubation criteria are met. In general, children are extubated in the OR only when there is insufficient PACU staffing, irregular hours, and most recently during the COVID pandemic, when there was a temporary extubation moratorium designed to minimize infection risk for nurses. We hypothesized that for children undergoing common general surgical procedures, PACU extubation is associated with less OR time than OR extubation and leads to no increased risk of airway complications. We retrospectively reviewed the records of children under 18 years of age who underwent either laparoscopic appendectomy, inguinal hernia repair, or pyloromyotomy over a 2-year time period. Exclusion criteria includes transfer to or from a critical care unit or PACU holds. In total, we reviewed 1,153 PACU extubations and 194 OR extubations. Children who underwent inguinal hernia repair and were extubated in the PACU left the OR 4.5 minutes after the end of the procedure, which was 8.5 minutes faster than those extubated in the OR. After laparoscopic appendectomy, PACU extubation was associated with a 6-minute reduction in out-of-room time. Similarly, infants who underwent pyloromyotomy were extubated in the PACU left the OR 6 minutes earlier than those extubated in the OR. For inguinal hernia repair, PACU extubation was associated with an 11% decrease in total OR time and a longer PACU course. The impact on OR time was even greater for appendectomy, with a similar extended PACU course. And after pyloromyotomy, there was also a 16% reduction in OR time and an increase in PACU stay. Extended PACU stays correlated with the average time from PACU arrival to extubation, which ranged from 5 to 17 minutes. Incidence of airway events after PACU extubation was very low, even for infants who underwent pyloromyotomy, and was similar to what was found after OR extubation. Most airway events were oxygen desaturations, usually in the 80s, and all resolved with bag valve masking by a nurse without re-intubation. There was no correlation of post-extubation desaturation events with either rapid or delayed PACU extubation. In summary, PACU extubation was associated with a decrease of up to 7 minutes or 16% in OR time. Airway events were unusual, mild, and similar in incidence to OR extubation. We conclude that a practice of PACU extubation might yield up to $320 in savings for these common operations, and perhaps more when the opportunity cost of fitting more short operations into a schedule is considered. Furthermore, PACU extubation is at least as safe as OR extubation, diminishes potential pressure on anesthesiologists to extubate deep in the OR. Thank you for your time.
Thank you, Parisa. The invited discussant for this paper is Dr. David Klima from Boise, Idaho.
I want to congratulate Ms. Oviato on her presentation on the impact of PACU extubation on safety and OR efficiency. As health systems move away from fee-for-service and towards value-based care, safe alternatives that can improve efficiency and decrease the overall cost of care for patients has become paramount for hospitals across the country. In light of this, I have a few questions. First, while your hospital has done a great job with decreasing OR time, the model has the potential to overwhelm PACU and as well as PACU staff and availability. How many patients had to be excluded from the data due to a PACU hold? And did you record the overall PACU time? My second question is, at our hospital, the anesthesiologists oftentimes have 3 to 4 patients at a time. And I can definitely see a CRNA intubating a patient at the same time as patients being extubated in the PACU. It seems feasible that patients could be intubated at the same time, and who is responsible for that decision to extubate and who is present during that extubation? Our third question is, for a hospital that does not do this routinely, what would be the biggest hurdle to confront in making this process happen? Once again, thank you very much for allowing me for the opportunity to discuss this presentation, and I applaud the authors on their findings.
Thank you so much for your warm welcome, Dr. Klima. I'll go ahead and get started answering your questions in order. So in terms of how many patients were put on PACU hold, 139 patients in our initial query, or about 3% of our initial query, were excluded due to PACU holds. At Rady, PACU holds don't necessarily happen because of delays or problems in extubation. However, it could just be that at certain times of the day, we tend to be busier, at least anecdotally, as at any hospital. We've been practicing PACU extubation as our standard protocol for several decades, and we haven't ever felt consistently overwhelmed, or else we still wouldn't have this protocol in place. The second part of that first question, to answer you, the PACU time was extended for patients who were extubated in the PACU compared to patients extubated in the OR, but only by a few minutes on average for each procedure. And as we've shown, those few minutes are much more costly if done in the OR, and we can still produce the same outcomes in terms of respiratory incidences. The second question that you asked was about who's responsible for PACU extubation. At Rady, our protocol is that we have PACU nurses who are very comfortable and in fact advocates for this, for them doing this role, who are responsible for extubation, and they only extubate a patient in the PACU after certain criteria, part of our protocol, are met, including facial grimacing, conjugate gaze, et cetera, as listed in the presentation. However, if an emergency does occur or help is needed, we do have 2 anesthesiologists who are always on call for PACU issues specifically. And as well, we can do an overhead page for anesthesia stat so that any anesthesiologists, we have 18 at a time at the hospital, who are not in an operating room will come. So we do have several layers of support there. And then your third question was, what is the biggest hurdle to instituting this? At a new institution that doesn't regularly do PACU extubation, the biggest hurdle would probably be PACU nursing training. And I say that because new nurses might not be familiar or as familiar with extubation. And even nurses that are trained in PACU critical cares are familiar with extubation in a critical care setting, but that's different than extubation from anesthesia emergence. So one would be teaching nurses, whether that's spending time in the OR or through an anesthesiologist, to recognize those signs of emergence from anesthesia and recognizing signs of respiratory distress or laryngospasm, et cetera. 2 would be, at least initially, having a medical provider who is an expert in recognizing those signs and managing airway issues, such as even a CRNA or a PACU respiratory therapist in the PACU available. And then 3 would just be having quality improvement studies, as with any new protocol, just to ensure that it's regularly being reviewed and is safe.
Thank you, Parisa and Dr. Klima.
Our next abstract in this session will be presented by Dr. Alexander Yang from Harvard Medical School. His presentation is entitled Functional Side-to-Side Splenorenal Shunts to Treat Extrahepatic Portal Vein Thrombosis in Children.
Extrahepatic portal vein thrombosis is one of the most common causes of portal hypertension in children who don't have liver disease. And even though these patients generally have normal intrinsic liver function, the obstruction to normal portal flow can cause the typical sequelae of portal hypertension. And these patients usually present with splenomegaly and upper GI bleeds. Surgical shunting procedures, which are really the definitive treatment for EHPVT, have evolved over the years, and a variety of methods exist. One of the preferred methods is the Rex shunt, which is essentially a conduit vein that bypasses the portal vein thrombosis. And though it does return portal circulation to the liver, this method has been associated with high post-shunt thrombosis rates and requires a patent distal outflow target. Another shunting method, the distal splenorenal or Warren shunt, selectively diverts portal flow to the left renal vein, but it requires pretty significant splenic vein mobilization. So both techniques really involve extensive dissection and exposure in a very hostile portal hypertensive operative field. And so at our center, we've utilized what we term a functional side-to-side splenorenal shunt, or FSRS, which we believe really provides a technically less challenging alternative to existing techniques. In the pediatric portal hypertension population, the left adrenal vein and inferior mesenteric vein are often dilated, which can be seen on preoperative imaging. These veins are in a position quite well suited to serve as a conduit between the splenic vein and the left renal vein. In one version of the FSRS, a dilated left adrenal vein is divided and then anastomosed in enticide fashion to the splenic vein. In the other version, the proximal end of the IMV, or one of its dilated collaterals, is anastomosed to the side of the left renal vein. Both versions essentially create an H-type side-to-side splenorenal shunt with only one anastomosis and without the need for extensive dissection of the portal triad or behind the pancreas. And so we retrospectively reviewed all patients with a diagnosis of EHPVT who underwent an FSRS procedure at our institution over an 18-year period. And of the 12 patients reviewed, all presented with splenomegaly and esophageal varices, 11 with GI bleeds, and 4 with ascites. 5 patients subsequently received an FSRS that utilized the left adrenal vein as conduit, while the remaining shunts used the IMV. The mean age at the time of operation was a little over 6 years. And as an example, the following is preoperative imaging from one of the patients in our cohort. And based on the finding of a dilated left adrenal vein around 5 millimeters in diameter, a decision was made to pursue an enticide left adrenal to splenic vein shunt. Here's an intraoperative pre-anastomosis view of the exposed left adrenal vein. And as you can see, once divided, it can very easily be mobilized and approximated to the splenic vein. Out of the 12 patients who received an FSRS, there were no cases of recurrent variceal bleeding, no episodes of shunt thrombosis, and no shunt reoperations required. We also observed a significant pre- to post-shunt decrease in the mean portosystemic pressure gradient. One patient required an IR venoplasty to dilate a narrowed shunt, and there was one sudden cardiac death in a patient with severe congenital cardiac anomalies that was unrelated to shunt complications or to portal hypertension. Surgical shunts are an important adjunct in the treatment of EHPVT complications, and in a patient with suitable anatomy who is a poor candidate for traditional shunts, the inferior mesenteric vein or left adrenal vein can effectively serve as a conduit in a non-selective portosystemic shunt with minimal dissection and one anastomosis.
Thank you, Dr. Yang. The invited discussant for this paper is Dr. Bhargava Mullapudi from Cincinnati Children's Hospital. The senior authors for this paper are also present with us, Drs. Kim and Dr. Cuenca.
Hi, congratulations to MD candidate Alex Chung for writing a nice abstract. Alex, I do have a few questions for you. The next question I have for you is more of the technical aspect of it. When you do your preoperative venograms and such, so what size measurements are you looking for in your IMV or the adrenal vein to see if the reconstruction would be feasible? And also, adrenal vein can be quite tricky to work with, just as most shunts. It can be thin-walled and sort of kind of tough to reconstruct. Have you guys run into any problems doing that, or is it just as easy as IMV to do that?
To answer the first question about the size of the shunts and the anatomy, so we consider patients to be eligible for the FSRS if the caliber of their vessel, either the left adrenal or the IMV, was greater or equal to 4 millimeters in diameter. And these resulted in shunts that were typically around 10 millimeters in diameter. And I'll mention that size is a pretty important consideration here. Too small and it kind of inhibits the function of the shunt, and too large and it increases the risk of hepatic encephalopathy. There's been previous work done by Dr. Sarfe and colleagues out of UC Irvine, which has demonstrated that small 8 millimeter portal cable prosthetic H grafts quite effectively maintain portal flow, but they're still able to reduce the risk of encephalopathy by up to 68% compared to larger 16 millimeter grafts. And these smaller shunts were shown to still prevent recurrent bleeding. And so given the diameter of the vessel that we used is comparable to that of those smaller 8 millimeter grafts, we think our shunts can reduce portal pressures and still maintain enough portal flow to minimize encephalopathy risk. So we had 6 patients who employed the adrenal vein as a type of shunt, and then the remaining 6 employed the IMV shunt. In terms of technique, the anastomoses were end-to-end or end-to-side, depending on the situation. And they were made with 7/0 proline in running fashion, just because of the thin wall nature, as you mentioned.
Your abstract said that there was no thrombosis or rebleeding after this shunt reconstruction. So what kind of follow-up are we talking about for this? If you can elaborate on that.
To address the second question about follow-up, so in all our patients, shunt patency was evaluated on post-op day 1, and then subsequently at 1 month follow-up, either by ultrasound or CTA. We ultimately had 2 patients who were lost to follow-up, and the remaining patients had follow-ups ranging from 3 months to 4 years, with an average of 15 months between them. And shunt complications like rebleeding episodes continued to be evaluated for up to the most recent follow-up.
My next question is the platelet count. Usually after a rect shunt and such, we tend to follow the platelet count, which could improve from days to several weeks. So was there any follow-up on the platelet count from this type of shunt surgery to see which direction they go? If you can elaborate on that.
The platelet count question is a good one, an important one. We did record platelet counts. 10 of the 12 patients presented with thrombocytopenia, and out of those 10 patients, the majority of them had recovery to platelet levels above 100 post-shunt. The issue was that given the small cohort size, we didn't have enough power to really make a definitive claim about changes in lab results, including platelet count.
Congratulations on an abstract well written. Thank you.
Thank you very much for that interesting conversation.
Our next abstract in this session will be presented by Kevin Janik from the University of Wisconsin. His presentation is entitled Laser Hair Removal as Primary Treatment of Pilonidal Disease.
We have no disclosure. Pilonidal disease is an inflammatory process involving hair follicles in the gluteal cleft. There is a wide variety of treatments which supports the presumption that there is no silver bullet when it comes to pilonidal disease. Recurrence rates can be as high as 20 to 30%. However, postoperative laser hair removal has been shown to lower the risk of recurrence. We hypothesize that laser hair removal as a primary treatment for moderate to severe pilonidal disease would decrease the need for surgery and reduce risk of recurrence after surgical intervention if needed. We designed a prospective single-institution pilot study. We targeted 20 patients ages 13 to 35 who met inclusion and exclusion criteria. Participants underwent 4 to 6 laser treatments by a pediatric dermatologist and were followed for 1 year in surgery clinic. Persistent and recurrent symptoms after laser hair removal were managed operatively. Our primary outcome of interest was the incidence of surgery and the incidence of recurrence after surgery. Secondary outcomes included cost and quality of life. 22 patients were enrolled into the study and 18 began study procedures. 77% of enrolled patients were male with an average age of 16.2 plus or minus 2.3 years, and an average duration of symptoms was 24 weeks. Of the 18 patients that started laser hair removal, 15 completed the course. 3 patients withdrew, primarily due to COVID. After LHR, 10 out of 15 patients had resolution of disease. However, 5 had recurrence within 1 year and underwent GIPS procedure. 5 of 15 patients remained symptomatic after LHR. 3 resolved after 1 GIPS procedure, and 2 patients underwent an additional procedure. Overall, the relative risk of surgical intervention of patients who completed LHR was 0.667, compared to patients who would have been offered primary excision. For example, this patient underwent 6 laser treatments. He experienced significant decrease in hair follicle density, closure of pits, and resolution of symptoms. This patient had 4 treatments. However, after the second treatment, developed a nodule to the right of his gluteal cleft, which required treatment. After completion of LHR, he underwent GIPS and had a good result with closure of central pit and abscess cavity. This patient had very dense hair and a large sinus. He underwent 6 treatments with great improvement. At his follow-up appointment, however, he developed recurrent drainage and underwent surgery with resolution of disease. Secondary outcomes were assessed by the Dermatology Life Quality Index and Children's version for ages 13 to 16. These are standardized, validated instruments that assess the impact of skin conditions on patients' quality of life using these topics. On the left is their baseline scored enrollment, and on the right, their most recent survey taken. Most patients had an improvement in quality of life index, however, did not reach statistical significance, likely due to limited numbers. To evaluate if laser hair removal was an appropriate use of resources, we compared costs of study patients to historical controls. Laser sessions were valued at $300 per session. LHR had a statistically significant cost reduction of $3,260 with a p-value of 0.003. This is likely due to the cost savings of surgery and avoidance of postoperative complications for patients who responded well to laser treatments. There are several important limitations from our study. First, it's a single institution, single-arm pilot study with limited sample size and a disease process with great heterogeneity. Like many clinical studies over the last year, we've had some interruptions and modifications due to restrictions imposed by the pandemic. In conclusion, laser hair removal may provide a well-tolerated, effective, and economical primary treatment strategy for patients with moderate to severe pilonidal disease. Further studies are needed to determine which patients would benefit most from this primary treatment strategy, and should include a multi-institutional randomized controlled trial comparing LHR to standard of care. I would like to acknowledge our study team and funding sources. Thank you very much for the opportunity to present.
Thank you, Dr. Janik. The invited discussant for this paper is Dr. Aaron Lipscar from Cohen Children's Medical Center.
Thank you, Dr. Janik, for that presentation of the paper on laser hair removal. I do have a few questions about this pilot study, and I guess the first one where I'll pause at is on the cost issues, both on who's paying for the laser, both in the study and then in general, is this an insurance-covered procedure? And second, why was there such a cost differential between the historical control?
Thank you very much for the questions, Dr. Lipscar, and thank you for the opportunity to present our work. So about the cost question, one of our main motivations for undertaking this study was because we had several patients with challenging disease that we wanted to be able to treat with laser hair removal, but it wasn't covered by insurance. And so we wanted to generate some data that we could use to approach the insurance companies and say, hey, this might be a reasonable treatment strategy. We then developed our protocol to allow us to explore this. And we asked our hospital administrators how much the laser hair removal sessions would cost. And typically they do this for around $600 per session for cosmetic procedures, but estimated a 50% discount for medical treatment. So we quoted each of our sessions as around $300 per session. And we applied for an institutional grant from an organization within our institution for clinical trials, and a supplemental grant from the Department of Art Dermatology. And used this money primarily for payment of the treatments. And these were done at our facility with a pediatric dermatologist. I believe that the cost difference between our study patients and the patients that were treated with historically, all of those patients had primarily wide excision and had extensive wound care follow-up, and some of them had additional surgeries that significantly contributed to the cost. So I think that most of the cost difference, some of it was in saving some of the surgeries because a third of our patients didn't require surgery. And the patients that had surgery had a decreased cost primarily from, I think, follow-up visits and wound complications.
Yeah, that's great. I guess the follow-up question then is, the treatment modalities have changed so much towards what we call the GIPS procedure, or the minimal pit excision and sinus excisions. That's really seems to be becoming the standard of care in pediatric surgery. And if that's the cost difference, how do you compare to that? And also, how do you compare it to a specific algorithm with or without laser in terms of managing a patient with pilonidal? And I guess that can lead to the last question, which is, what are you going to do with this data?
So to answer the first part, our institution has been doing the GIPS procedure for just the last several years. I think that some of the long-term data that we have available, there's a necessary follow-up period of 2 to 5 years to know which of these patients are going to recur, although a lot of them will recur within the first 1 to 2 years. So I think when comparing direct cost comparisons, we need to have a longer-term follow-up for them. So regarding the next steps, I would hope to apply for an R21 grant to be able to do a multi-institutional randomized trial where we would randomize patients to either preoperative laser hair removal or postoperative laser hair removal, because I think that is, there's a lot of protocols being developed with a minimally invasive pilonidal surgery and adjuvant laser hair removal to be able to see if there's a cost difference between those or a difference in recurrence rates.
That's great. Yeah, and congratulations. I think this is such a difficult question, as you mentioned in your presentation, because of the heterogeneity of the disease. You should be applauded for really trying to contribute to our understanding of how to utilize hair removal techniques in complex pilonidal.
No, thank you very much, Dr. Lipsker and the committee.
Thank you, Dr. Janik and Lipsker, for that interesting discussion.
Our next abstract in this session will be presented by Hira Ahmad from Nationwide Children's Hospital. Her presentation is entitled Laparoscopic Assisted Colonic Derotation Utilizing Fluorescence Imaging in a Patient with Hershbergs Disease Proximal to the Splenic Flexure.
We present a case of an 8-month-old male who was diverted with an ileostomy as a newborn and colonic mapping. His transition zone was proximal to the splenic flexure, therefore we employed a laparoscopic assisted approach to avoid a laparotomy incision. We started by placing 1 port in the umbilicus and 2 additional ports. The operation started with laparoscopic lysis of adhesions. Next, a site is chosen on the redundant sigmoid colon for the biopsy. This site is exteriorized via the umbilical incision. A biopsy is taken and sent for evaluation, and the biopsy site is closed with interrupted long-term absorbable sutures. The port in the umbilicus is reinserted, and the left colon is mobilized using both sharp and Bovie electrocautery along the white line of Toad. Next, the splenic flexure is mobilized using ultrasonic energy device to maintain hemostasis. A second biopsy is sent from proximal to the splenic flexure in the similar fashion as seen marked by the sutures. Care is maintained to identify and preserve the marginal artery. The mobilization of the colon continues, ensuring to stay proximal to the branches of the marginal artery, which will eventually supply the pull-through segment of the colon. The patient is then placed prone for transanal mobilization. We start by placing the pins to expose the dentate line. These pins are then moved more proximal to hide the dentate line. Permanent sutures are placed 1 cm proximal to the dentate line to provide circumferential traction, and the rectal dissection begins in a Swenson plane. The dissection continues in the Swenson plane to the level of the levators. Once adequately mobilized, the opening is packed with a Raytec, and the patient is placed supine now. Laparoscopic mobilization of the rectum is continued transabdominally until it is met with the transanal mobilization of the rectum. The entire rectum is pulled into the abdomen. The sigmoid colon mobilization is completed, ensuring to identify and protect the ureters. Next, the previous ileostomy site is taken down, which allows for exteriorization of the bowel for further mobilization. Once the colon is exteriorized, additional length is gained by maintaining the marginal artery. The blood supply is thought of as a Y, and it is turned into a V by taking it down proximally and thus gaining more length of the colon. This is demonstrated in the following 4 pictures. This is a Y, which we will turn into a V and gain additional length. We make sure to tie the vessel. We avoid the use of electric device to ensure no damage is done to the marginal vessel, which is the only blood supply for the eventual pull-through segment. The colon is then derotated such that the cecum now lays in the right upper quadrant and the proximal colon is brought down for the coloanal anastomosis. Since this colon is maintained on the marginal artery from the ileocolic branch, we always check the vascular supply using the SPY Elite technology. The dye is injected and the SPY Elite shows good blood supply to the planned area of the anastomosis. The planned pull-through segment of the colon is marked to ensure correct orientation during the pull-through. The ileostomy is matured through the same incision and standard coloanal anastomosis is performed. The patient did well post-op and was discharged home on postoperative day 4.
Thank you, Dr. Ahmad. The invited discussant for this paper is Dr. Rebecca Rentia from Children's Mercy Hospital in Kansas City.
Dr. Ahmad, thank you so much for your wonderful presentation. I have a few questions on the work and the video that you just showed. So what are some pointers about fluorescent imaging utilization in the operating room? Are there any age or weight limitations? And can you describe the administration of indocyanine green or ICG and how you can visualize an image?
Great, thank you so much for that question. Just a fun little fact, ICG was actually developed by Kodak Labs back in the 50s, and it's been used for renal or retinal angio since the 70s. ICG utilizes a fluorescent dye, and it allows us to assess tissue perfusion in real time. We use a machine, something called the SPY Elite imaging system, which is a mobile unit with a computer and a camera head and can be used for both open and laparoscopic cases. We're able to visualize tissue microperfusion for up to 7 to 10 millimeters. To administer ICG, we recommend, and actually manufacturer recommends dissolving it in water instead of saline because it's more stable in water. It's injected intravenously, either central or peripheral access is fine. It strongly binds to lipoproteins in the blood, which is great because then it stays within the blood vessels. And it's excreted via the hepatobiliary system. So once it's injected, the surgeon should be ready when they're ready to inject it, because you can see it within 30 seconds to 2 minutes, and then its half-life is about 3 to 4 minutes. So once the surgeon's ready, they should request that it be injected. Once it's injected, the camera head is turned, and you can switch from real life into the fluorescence light, and in real time be able to see within 2 minutes the tissue perfusion. The dose that we recommend or that we've used is about 0.1 to 0.3 milligrams per kilo. The industry recommends maximizing at 2 milligrams per kilo, which is an advantage from our end that we can actually repeat these doses without too much toxicity seen. There's a warning for patients who do have iodine allergy, because it can cross-react with that. It should also be avoided in pregnant patients. It does require specialized equipment, but once it's purchased, the cost of it is actually pretty cheap. It's about $80 per use for the equipment as well as ICG. We've used it in patients as low as 0.3 kilos with success, and have actually successfully used it.
That's really wonderful. Another question I had was, how are you quantifying perfusion, and what are you looking for when making a surgical decision?
Sure. So one of the drawbacks of ICG is the that there's still no strict analytical measures to objectively quantify the signal intensity. There's been some studies that are attempting to quantify the signal intensity with the postoperative stricture rates or tissue necrosis, but the results of those are still pending. So really the evaluation of the images is still very subjective and it depends on surgeon's judgment.
Okay. And when in relation to ligating the various branches are you performing the ICG?
We're using it as in more complex patients, we're using it as a surgical decision making. So especially when we're creating these tissue grafts or doing derotations in functional constipation or Hershberg patients, we use a vascular clamp on the vessels, something called a bulldog clamp, which is everyone's familiar with. We clamp the vessel and then we inject ICG and look at the tissue perfusion. And if it's adequate, only then do we ligate the vessel. So it helps us a lot in real time in surgical decision making.
Great, thank you so much.
Thank you for your questions.
Thank you, Drs. Ahmad and Rentia.
Our next abstract in this session will be presented by Dr. Christopher DeBoer from Lurie Children's Hospital. His presentation is entitled National Trends and Outcomes of Thymectomy for Pediatric Myasthenia Gravis.
Thank you all for attending this presentation today. My name is Christopher DeBoer, and I'll be discussing trends, outcomes, and efficacy of thymectomy for pediatric myasthenia gravis in the United States. The authors have no disclosures. For some background, we now know that thymectomy is an accepted treatment for pediatric myasthenia gravis. Additionally, video-assisted thoracoscopic surgery, or VATS, is increasingly adopted as a surgical approach. However, gaps in knowledge remain. Studies looking at thymectomy for pediatric myasthenia gravis are limited to small single institution studies. Also, classifications of myasthenia severity are not validated in children, so efficacy of thymectomy as a treatment for myasthenia gravis is unknown. Therefore, our aims were twofold. First, to describe trends and outcomes of pediatric thymectomy for myasthenia gravis across U.S. children's hospitals, and two, to determine the efficacy of thymectomy as a treatment for myasthenia gravis by measuring myasthenia-related hospital admissions and medication burden as a proxy for disease severity, which I'll explain more fully later. To do this, we performed a retrospective cross-sectional study. We utilized data from the Pediatric Health Information System and included children under 19 years old who underwent thymectomy for myasthenia gravis from 48 children's hospitals with available data from 2004 to 2020. We analyzed annual rates of thymectomy, patient demographics, and outcomes by surgical approach for AIM-1. We then looked at MG-related admissions and compared them for a year prior, as well as a year following thymectomy, using a novel proxy for myasthenia gravis severity. We found that VATS thymectomy increased over time, although there was a persistence of the open approach. And we found that this was explained by a preference for the open approach performed by a few hospitals, represented on the right side of this image. In an analysis of open versus VATS thymectomy, we identified 515 patients in FIS. 70% were female, and the mean age was 12.1 years. The open approach was associated with increased length of stay and ICU admission, with no differences in surgical complications, and no mortalities were observed. For AIM-2, we sought to determine the treatment efficacy of thymectomy for myasthenia gravis. To do this, we looked at patients in our cohort who had at least one myasthenia-related admission before their thymectomy, and found 289 patients who met this criteria. We then measured the mean number of myasthenia-related admissions and the mean number of modes of myasthenia therapy and compared them before thymectomy to after thymectomy. FIS provides pharmacy data for the analyzed hospital admissions, allowing us to identify the intensity and modalities of myasthenia medical therapy. For example, we presume that an admission during which a patient receives IVIG, plasmapheresis, and steroids is more severe than an admission where a patient received an acetylcholinesterase inhibitor alone. We found that there were mean decreases in all categories of therapies, in mean number of admissions, and in mean total number of therapies. And nearly all of these categories were significant decreases. In conclusion, The surgical approach to pediatric thymectomy has shifted from open to VATS over the last 16 years. VATS thymectomy is associated with decreased length of stay and rates of ICU admission, with no difference in surgical complications compared to the open approach. Thymectomy also appears effective in the pediatric population, using myasthenia-related hospital admissions and medication burden as proxies of disease severity. Thank you all for listening to this presentation. I'll take any questions now, or you can direct them to these communication methods below. Thanks again.
Thank you, Dr. DeBoer. The invited discussant for this paper is Dr. Yan Shi from University Hospital's Rainbow Babies and Children's Hospital.
Chris, thanks for that great talk on thymectomy in pediatric patients. It's not an incredibly common disease or procedure for many of us. So there's still a lot of unanswered questions regarding how to best manage this disease in children. I'd like to start off by asking you, so myasthenia gravis is divided into patients with thymomas and those without. And their presentation, prognosis, and treatment differ quite a bit between the two groups. Were you able to differentiate between these two groups in your analysis?
Yeah, thank you for that excellent question. This is definitely something we thought about going in, and as you said, stratification by those subgroups would be an important thing to do. We were limited in phys by identifying patients with thymoma based on ICD coding. And in looking through secondary diagnoses, we only found 19 children with a ICD diagnosis of thymoma. So we're unfortunately not able to statistically do an analysis by those subgroups.
Another part of your abstract was looking at VATS. And there's those that question whether patients who undergo VATS are more likely to have residual thymic tissue left behind. Were you able to see any of this in your analysis? Did VATS appear to be as effective as open thymectomy based on the outcomes you measured?
Yeah, another very important question, another sort of driving research question for us. Like you saw, in terms of clinical outcomes, we were able to show that VATS was associated with decreased length of stay, decreased ICU admission, without an increase in complications. Regarding efficacy, so far, our analysis has been limited to a cohort as a whole with the open-end VATS cases together. I was able to look at one variable in anticipation of this, which was admissions, and stratify it by VATS versus open, and found that both of them showed a decrease in myasthenia-related admissions, and they don't appear to be, one does not appear to be superior to the other.
Were you able to see any, were you able to compare your results with any corresponding adult data just to see if the outcomes were similar between the two age groups?
Yeah, there's a few studies in the adult population that have taken a similar approach. I think the best evidence that we found was a randomized controlled trial was published in the New England Journal in 2016 that looked at prednisone versus steroids plus open thymectomy in the adult population, and found that thymectomy resulted in a decrease in myasthenia admissions and decreased burden of steroids. And so that's one paper we look to model after. Caveats being that was all non-thymomatous myasthenia, and like I mentioned, that was all open surgery. There are a few other institution-specific and retrospective smaller studies that have also demonstrated the same, and have been included in some systematic reviews that we looked at as well.
Great. And then finally, if you could pick one thing from your study that we should take away, what would it be?
Yeah, I think the main finding for us and what's going to drive our research question going forward is contributing to this gap in knowledge that we feel like we're demonstrating that thymectomy is an efficacious treatment for myasthenia in children. And looking forward into the future, wondering, now that we have a less morbid surgical approach in VATS, will thymectomy be a more common treatment option for kids with myasthenia?
Well, I'd like to thank you for answering those questions. Great talk, Chris, and thanks for presenting your abstract.
Yeah, thank you so much for the questions, and everyone else for listening and participating. Appreciate it.
Thank you very much for that interesting discussion.
Our next abstract in this session will be presented by Syed Arshad from the University of Texas at Houston. His presentation is entitled Multi-Center Assessment of Cryoanalgesia Use in Minimally Invasive Repair of Pectus excavatum.
Hi, I'm Syed Arshad, and I'll be presenting a multi-center assessment of cryoanalgesia use in minimally invasive repair of Pectus excavatum. Here's our disclosure. Pectus excavatum is the most common congenital thoracic deformity of the anterior chest, with severe cases resulting in pulmonary and cardiac dysfunction. Surgical repair includes a minimally invasive repair of Pectus excavatum, also known as the Nuss procedure. It's traditionally considered a painful operation, with patients remaining in the hospital for a period of time and often requiring a significant amount of opioids following surgery. Cryoanalgesia has been used as an adjunct to postoperative pain control. This works by temporarily ablating intercostal nerves by cooling them to -65 degrees Celsius, destroying axons distal to the site of cooling. The outer nerve structure is left intact, allowing for nerve regeneration, which results in an analgesic effect which lasts for weeks to months. Therefore, we hypothesize that the use of cryoanalgesia in patients undergoing this procedure would be associated with decreased postoperative opioid use and hospital length of stay. We performed a multi-center retrospective cohort study which included 19 children's hospitals from the Pediatric Surgical Research Collaborative. This included pediatric patients undergoing this procedure from 2014 to 2019. Our primary outcome was postoperative opioid use as measured by oral morphine equivalents per kilogram, and secondary outcomes included 30-day length of stay, length of operation, time under anesthesia, and rates of complication within 30 days. For our statistical analysis, we compared patients who received cryoanalgesia to those who did not. Univariate and multivariable analyses adjusting for confounders and within-center clustering were utilized. Overall, we had 936 patients submitted to the study and 49 were excluded. Of the included 887 patients, 135 or 15% received cryoanalgesia. Patients were similar by age, sex, body mass index, Haller index, race, insurance status, and presence of comorbidities. The cryoanalgesia cohort had a larger proportion of patients with symptomatic Pectus excavatum. Looking at our primary outcome of postoperative opioid use on univariate analysis, patients who did not receive cryoanalgesia used a median of 5.6 oral morphine equivalents per kilogram, while patients who received cryoanalgesia used 1. Additionally, preoperative gabapentin, continuous infusion catheters, and regional block were also associated with reductions of postoperative opioid use, while PCA and epidurals were associated with increases. However, on adjusted analysis, certain adjuncts were associated with no benefit or higher opioid use, while cryoanalgesia remained associated with lower oral morphine equivalents per kilogram. With adjustment, this accounted for a 4.3 oral morphine equivalent per kilogram reduction in postoperative opioids per patient when cryoanalgesia was used. Looking at length of stay on adjusted analysis using the same covariates, cryoanalgesia was associated with a 1.4-day reduction in length of stay. Another item of concern with cryoanalgesia is operative and anesthesia time. We saw a 19-minute increase in operative time. However, there was a similar time under anesthesia, and this makes sense as cryoanalgesia was typically replacing other intraoperative adjuncts. When looking at complications, we found a similar rate of overall complications between groups. This included the rate of readmissions and reoperations. However, constipation and urinary retention were more common in the no cryoanalgesia group. In conclusion, cryoanalgesia is a promising adjunct in the care of pediatric patients undergoing minimally invasive repair of Pectus excavatum. In our study, its use was associated with decreased opioid requirements and length of stay, with no increased rate in overall complications. Cryoanalgesia should be considered for inclusion in pain control protocols for patients undergoing minimally invasive repair of Pectus excavatum. Thank you for the opportunity to present our work.
Thank you, Dr. Arshad. The invited discussant for this paper is Dr. Mark Mazziotti from Texas Children's Hospital. Also joining us is Dr. Ko-Jin Sao, as the senior author on the paper.
Thanks for letting me review this paper and ask you these questions. I just wanted to congratulate you, Dr. Arshad, on an excellent study. My first question is, given the number of centers involved, what methods were used to standardize the cryoablation technique to ensure each center was performing the technique the same? Additionally, was there a standardized pain regimen applied to all the patients, or was each center allowed to manage pain as they saw fit? And lastly, was the operation itself standardized across the centers?
Thank you, Dr. Mazziotti, for the kind comments. So
This was a retrospective observational study, so there was no standardization performed within our study protocol. And with that said, there's one main commercially available cryoprobe that's FDA approved for pediatric pectus surgery. So there's a manufacturer's protocol for that. One thing we did see when analyzing the data is that there's a fair amount of variation in pain management for pectus patients across the country. We chose to capture that as it's a reflection of the current practice of pediatric surgeons, and therefore we hope the results will be more generalizable. It also provides a basis for our next study, which we're planning, which will be a prospective study using standardized protocols. Therefore, the differences in outcomes can be more directly compared.
Great. You clearly showed a marked decrease in the oral morphine equivalents used in the postoperative period. Did you happen to look at quantity of opioid use following discharge, or if the pain medicines were refilled as outpatients?
Yeah, so that's very difficult to track once a patient goes home, to know exactly what they've taken, and even more so retrospectively. We were able to, however, capture the amount of opioids that were prescribed at the time of discharge, and we did see a difference there. The patients that received cryoanalgesia were given prescriptions for a median of 3.4 oral morphine equivalents per kilogram, compared to 6.6 in patients who hadn't received cryoanalgesia. This was statistically significant. However, some of that difference may also be due to change in practice over time.
Okay. You also showed a marked decrease in the length of stay of patients who had received cryoablation. And this decrease in number of days would imply a possible cost savings, although this could be counteracted by the increased operative time that you noted and possibly the cost of the equipment itself. Did you perform a cost analysis to investigate this?
Yeah, we did not perform one in this study. It is a goal of our future study. There is one published study that had shown some initial data of cost savings with the use of cryoanalgesia. In our study, although the operative time was longer, the time in the operating room and time under anesthesia were still similar, as cryoanalgesia was typically replacing other adjuncts. Oftentimes, the cost savings from each additional hospital day is more than enough to displace the cost of that device. So we do believe that there would be a cost savings and hope to study that prospectively.
Okay, based on the data that you've presented, do you think that cryoablation should be the standard of care? The other question I had was, you noted that you looked at the complications or the readmissions, the ER visits, and the reoperation rates, and you noted they were the same between the groups. Did you look at the incidence of allodynia in the cryoablation group?
So you've touched on one of the aspects of cryoanalgesia, which we still need more data on, and that's long-term outcomes, that being 5 and 10-year outcomes. Currently, there's a few studies which have noted 1 to 2 year outcomes and showed rare occurrences of this. Allodynia and similar complications take a few months to reveal themselves after the operation, and we found that at least in retrospective chart review, it's not typically well documented. So our study was limited to outcomes within 30 days, so we did not capture this. But again, something we'd like to study prospectively. As far as standard of care, I think it's difficult to recommend this as a standard of care at this time based on retrospective data.
And I want to congratulate you again on a great paper and all your co-authors too.
Thank you very much, sir.
I'm the senior author, and Arshia is attending on the study. We appreciate not only his hard work, but obviously contributions from all the centers and the Pediatric Surgery Research Collaborative, so that without everybody's contribution, we wouldn't have as big of the impact of a study that we think we have here. So thank you very much.
Thank you, Drs. Arshad and Mazziotti.
This concludes our general pediatric and thoracic session. We thank you for watching and thank all of our presenters and invited discussants.